Hi, thank you for giving us the opportunity to present to you how our GSD service works at the Evelina London. I'm Gemma, one of the metabolic nurse specialists, and this is Jo, one of our metabolic dietitians. Just so you're aware, Jo and I do not have any conflicts of interest for this conference today. To give you an idea of how our service looks, we're very fortunate to have a consultant with a specialist interest in GSD. We have one named consultant for our whole GSD patient cohort. We currently have 3 whole-time equivalent nurse specialists and 4.3 whole-time equivalent metabolic dietitians, and we split our time between the whole service whilst covering the GSD patients too. We have 64 patients with a confirmed GSD genetic diagnosis and 3 that we're waiting for genetic results on at the moment, but we are treating as GSD. Out of those 67 patients, we currently have 28 that undertake home glucose and ketone profiles, which I'll talk a little more about in later slides. The trajectory that our GSD patients take is quite possibly very similar to all of your services. At the Evelina London, we'll always admit our patients in the first instance, following a referral, to ensure that we implement a safe treatment plan as soon as possible for these children. The patients are then readmitted frequently over the next 12 months or so to ensure that they have stability in their plan. We know that as we start to treat the GSD, then instability and hypoglycemia becomes more pronounced and adjustments are required more frequently. Once we have a period of stability, they'll be admitted less frequently for profiling. The GSD type 0, 3, 6 and 9s will often be taught home glucose and ketone profiles as time progresses. Our type 1A and type 1B patients will now often have a CGM fitted in the community in between their inpatient profiles. All patients have monitoring bloods, imaging, heights and weights, and they're done on a regular basis. This may be during their inpatient stays or may be done in outpatient clinics. It's down to where the patient is in their trajectory, but they may be seen in clinic usually on a 6 to 12 monthly basis. The GSD type 1 patients, they have frequent inpatient stays and so don't often come to clinic for quite some time. So all of their monitoring is done when they are inpatients. We're extremely fortunate to have an adult metabolic service in the same hospital site. So when our GSD patients reach 18 years old, their care is transferred over to their service. So I'll explain a little bit about each part for you. As I said, we're fortunate in our hospital here that we have a dedicated ward that we share with our neurology patients and our neurology team that we admit our GSD patients to. This not only allows the patient direct access to the multidisciplinary team because we're quite often around, but it also ensures that our nursing staff on the ward are caring for our patients, have a good knowledge and skill set to be able to do this. And we find that continuity is key, which helps. We admit the GSD patients for a number of reasons, and that may be, as I said earlier, for routine profiles, starch loading, fasting. It might be the introduction of empagliflozin in our GSD 1B patients, and also importantly for education and transition, which can often be done as a day case. This chart gives an indication to you of some of the routine monitoring that we undertake on our patient cohort. The frequency of MRI and DEXA scans, just to be clear, are very dependent on a number of factors. For example, it might be when their last scan was, what their age is, the clinical state in their treatment at the moment, their tolerance to scanning. We don't often like to put patients through an anaesthetic just for their scans, and so we will base the decision to scan around these things. It's the same with DEXA scans. The younger patients don't often get them as frequently because, as you will be aware, there's not so much standardised data for that below 8 years old. So have a look at our admissions for the introduction of empagliflozin in our GSD 1B cohort. We have 8 patients with type 1B at the moment, all of which have started on empagliflozin. We have a starting age range of 0.9 to 14.6 years. All of our patients started EMPA as an inpatient and never as an outpatient. And the reason for that is we have seen a degree of instability in their biochemical control when starting EMPA, even at the lower doses. We generally prescribe EMPA to be given in 2 split doses and monitor the fractional excretion of the 1,5-AG in the blood and the urine. We undertake twice daily urinalysis to monitor for the glucose-urea, and we send patients home doing this in the initial period. We then readmit the patients again after 1 month, and this is again because we see further instability to their biochemical control after this period, and the patients often need further adjustment to their treatment plans. That might be that we give a little bit more carbohydrate due to the glucose-urea, or it might be that we reduce the dose of EMPA, both of which we have done. This graph is a good representation of one of our patients that we started on empagliflozin. And you can just see that even with the smaller doses, we can significantly reduce the levels of the 1,5-AG in these patients. This patient started on a dose of 0.45 milligrams per kilogram per height weight. He started with a 90-minute fasting tolerance. After a short amount of time, we were able to stop the GCSF very quickly. His fasting tolerance increased up to 120 minutes, so two hours. And we were able to insert a gastrostomy, and since then that has healed very well, and he has had no infections. He's also now started on a blended diet via his gastrostomy, and we have increased his fasting tolerance further. So it's a positive view of what empagliflozin can do in these patients. At the Evelina, we do home glucose and ketone profiling, and this was first introduced in our service in 2015. Initially, it was only ketone home profiling that we did, but the glucose was added in 2018. Home profiling, as I said earlier, is undertaken by 28 of our GSD patients, and that they are the patients with type 0, 3, 6 or 9. The aim of the home profiles was to get a more accurate biochemical profile on these children in their home environment, living their normal day-to-day life rather than being in hospital. As I'm sure you can appreciate, the level of activity when patients are in hospital is drastically reduced, and there are huge changes to their diet, as hospital food isn't generally food that families will cook and eat at home. We request a 48-hour profile, one day being a school day and the other day a home day, to ensure that we capture 2 different types of day for our patients. And ideally, we do ask for consecutive days. So maybe a Friday and a Saturday, or a Sunday and a Monday. Home profiles also mean that we're saving beds in hospital, and the patients miss less time from school and parents miss less time from work. The patients that we offer the home profiles on are not patients that are newly diagnosed. These are patients that have had a period of stability on their current feeding plan. The families they need to demonstrate to us that they have good adherence and compliance to their treatment plans. They have literacy skills and the ability to undertake these profiles at home to a good enough standard that we can base our clinical management decisions on. Home profiling is taught to families during an admission. A monitor is given to the parents, which they will then take home with them with the supplies. We recommend that parents use the monitor that we provide alongside the ward monitors to begin with, so that they can practice and become familiar with how the monitor works. We also provide information packs when they are introduced to this. That sets out expectations. It includes a competency document and information for schools about profiling too. Home glucose and ketone profiles are predominantly nurse-led, in that we keep a record of the patients that are due the profiles. We send out the requests and the supplies. We support the families being able to do the profiles. That might be on the phone, it might be talking to schools, and just revisiting with them each time, because they do quite often forget. We then collect the data when it's sent back into us, and we present it at our MDT home profile clinic. It's patient dependent, but we generally request home profiles on a 6 to 8 monthly basis, and more frequently if we've made recent changes to feeding plans. We always ask for a height and weight when they start the profile, and encourage them to document portion sizes and weights of food on their food diary. This allows for an accurate review of their diet. You can see a small copy of the diary card here. The families have to do a daily control of the monitor with the quality control testing and document the results, so that we can ensure reliability of the data. We also ask that they check their blood sugar and their ketone levels no more than 5 minutes before meals, snacks, feeds, starch doses, and also overnight feeds. This is because we know that within anything longer than that 5-minute window, there can be quite significant changes. More recently, we've introduced requesting that families do glucose samples 30 minutes post-meal times. And these results give us a good indication if the blood glucose is on the upper end of normal, then we may need to review the patient's diet, which we'll talk about a little later. So this slide just gives you or shows you an idea of why we chose the monitor that we use now for home profiles. A study was set up when we first introduced home profiling to compare whole blood samples and plasma samples in the lab to the bedside Nova meter and an Abbott meter. 28 patients were used when we gathered this data, with 138 measurements in total. The patients were tested during times of planned fasting, and this is because we then knew that they would be producing ketones. So we knew we would have some measurable data. The fasts were planned, either diagnostic or on children with GSD who are carrying out starch loads. The study showed us the accuracy of the meters at different levels, which was important as that's what we wanted to use the meters for. We were wanting the devices for looking at ketone levels on the lower end of the scale, so around 0 to 1, which is actually the opposite of what happens in diabetes. So these machines are geared up for looking at higher levels. So we were interested in the machine that was accurate at the lower levels. The Abbott meter performed poorly at lower levels and the Nova meter performed better. And that's why we went ahead and chose the Nova meter. As for our population, it was more reliable and acceptable bias. So looking at how we review our home profiles, we have 2 what we call home profile clinics per month. These clinics are multidisciplinary and are a space to review the home profiles in detail with the dietitian, the nurses and our named consultant. We're able to look at the child's weight and height. There is a meticulous review of the food diaries, including a look at the carbohydrate quantities in meals, timings, doses and feed volumes against what has been prescribed for them. If there are changes to be made or not, the results are always communicated to the parents via telephone and followed up in writing as well, so that things are clear for them. We are aware that one limitation to doing home profiles is compliance to the diet and the feeding plan. And that said, this also does have its benefits because we do see a true reflection of what actually happens at home, how we need to support the families and or potentially re-educate them. And I'll just show you an example of that now. So patient A is a patient with GSD type 9. At the time of this profile, he was 10 years and 4 months old. This is a reflection of his inpatient profile. So this was done in hospital. His feeding plan at the time was just 3 doses of cornstarch during the day and a bigger dose at night time. The family at the time had not been taught how to carb count. They were just advised to have 3 meals a day with some additional snacks. What we saw when we had a look at his 30-minute post samples was that the blood glucose levels, were peaking particularly high, giving us a clear indication that potentially he was having too much carbohydrate. What we did was we introduced carbohydrate counting and taught the family home glucose and ketone profiling so that we could review the effects of the education that we had provided in hospital. What we did is we set a carb limit for his meals to 35 grams per meal. When they resent the repeat home profile back in with the 30-minute post samples, it was quite clear that we could see from the food diary that they were not compliant with this treatment plan that we have given. And this is just an idea of the food diary that was given to us. So we can see that even the patient's post samples of glucose were still, up to the 8s and some in the 9s. So what we could see quite clearly, our dietitian scrutinised the feeding diary, and we could see that some of these meals were way above the target of 35 grams. What we did from this is we reduced the nighttime dose of cornstarch and we revisited the carbohydrate teaching with the families again. This is a copy, a review of his post profile. So after those changes of re-educating on carbohydrate counting, reducing the nighttime dose of starch, they repeated the profile. And actually what you can see is there is a reduction in the 30-minute post samples, giving us an idea that we have optimized control ever so slightly better. By limiting the carbohydrate, we can see that he's grown in height, whilst also losing weight. So we've optimized his growth there. Just to quickly go through with you just about our outpatient clinic, we have 2 clinics per month for GSD patients only. The clinic slots are 1 hour each. We try, where possible, to coordinate imaging on the same day if we need to. And at this clinic, they are reviewed by consultant nurse and dietitian, so we can get their heights, weights, we review their feeding plans, check their emergency regimen, and undertake education where needed or transition as the patients get a bit older. I'll hand over to Jo. Thank you.
Thank you, Gemma. So for the remainder of this talk, I'm going to talk a little bit more about the dietary practice at Evelina and how it may differ from other centres. I've listed some of the differences here, and I'll go through each one separately. So the first one, which I think is the most important, is that we use a height weight for all our calculations regarding protein, carbohydrate and starch doses. This is a typical child who presents to us is low, it has a high weight and a low height. And we have chosen to use the height weight because we want to fuel the brain and the lean body mass, not fuel the adipose tissue. So we use the lower weight and calculate this using a term, the height weight, which is the weight at which they would be if they're on the same centile as their height. And this can result in reducing the carbohydrate, the starch and the protein, which saves on calories. And this slide here, I hope can explain this. So this is a child that was referred to us, and it's a typical child with GSD. It has a height centile of less than 0.4 and a weight between the 2nd and 9th. And if you just use their actual weight, the child was 18.6. But if you use the height weight, you can see it's 16.7. So we would use this initially to use for our calculations, and we would be counting this for using this for the overnight feed. And you can see here we've worked out the protein based on their height weight and also their carbohydrate requirement as well. The next 3 points are about carbohydrate and starch. So historically, cornstarch doses are between 1.5 and 2 grams and are often given 3 times a day. And the carbohydrate overnight in the overnight feeds are often suggested to meet their basal carbohydrate requirements. But at Evelina, we don't increase the starch or their overnight carbohydrate just if they increase in weight. We don't automatically increase the doses. We would wait for a profile, and our aim is to provide the smallest dose of starch to give metabolic stability. We may start with something like 5 grams, then move up to 10 grams, and then bring them in for a profile and see how they, their metabolic status is with that. It also means then that their doses across the day can also vary depending on their activity. And then lastly, the carbohydrate quantities. Again, this varies. Some centres say to give regular carbohydrate at meals, some give certain quantities to do, and this is what we do at Evelina. We limit the carbohydrate to a specific carbohydrate amount, and again this can vary depending on the time of day and the activity. Just have one note to say is that if you've got a GSD 3 or 6 or a 9, again we may not just be using their basal carbohydrate requirements. If they can use protein for energy, we would be adding in additional protein rather than carbohydrate. This slide here, it's a bit busy, but I hope to, I've used one slide to sort of cover a number of topics. So here, this is a boy with GSD 1B, and firstly, I want to draw your attention that the carbohydrate per kilo per hour is the same across the day, so it's 0.44. But the actual doses of carbohydrates varies. You've got 11, 18, 15, and these we have tried to, we've given these varying amounts based on the feed interval time. So we know he can go 2.5 hours, but in the morning he's got nursery, so we only can do 1.5 hours in the morning. So that's why we've decreased the carbohydrate dose there, so it's 11 grams. You can see a little bit later on, for his interval, it's 18 grams and has a 20 grams cornstarch dose. But again, at 11:30, we've got 18 and we've increased the cornstarch to 25. And this would have been done on a profile. We would have seen that 20 grams just wouldn't have been enough for him. So we've increased that to 25 to improve his lactates there. And then later on at 4:30, again with the profile, it would have shown that he doesn't need as much carbohydrate. So we've reduced the dose, the cornstarch to 10. And because the feed interval is only 2 hours, we've given him a 15 gram carbohydrate dose there. So these diets, as you can see from that slide, can be very complicated. But the feedback we get from patients and from other centres is that we at Evelina, and I would like to say that we're proud of presenting our patient information and resources in a practical way that means that patients can actually comply with it. And over the next few slides, I'm going to give you some examples of this. The first one I'm going to talk about is how we limit carbohydrate. So typically for a patient that comes to us as a newly diagnosed patient, parents feel that carbohydrate is the thing that's rescued them. It's the thing that's kept them going. So then we start talking about limiting carbohydrate, and that can be quite confusing, and they're reluctant to do that. So we have to explain, and we do this from the early stage, of why it's important to limit the carbohydrate. And with compliance, we all know that if you explain to somebody why you're doing something, they're more likely to comply. So this next slide is a slide which we call our sad and happy liver. And we have used this in clinics, education days, and what we're trying to explain here is that if you have large quantities of carbohydrate, it gives you a large amount of glucose all at once. There's a large amount of glucose in your blood system, and then it goes into the liver and it gets stuck in the liver. It gets stored in the liver, and we know that storing it, we can't then get it out, and it's locked in there, and we can't then use it for energy, and that has problems with growth and other metabolic toxics. So what we want to do is we want to try and explain why we can't have a huge amounts of carbohydrates at one go. So we explain it in the happy liver in that we use cornstarch and we really limit the carbohydrate and carbohydrate exchanges, which means that we have a drip effect, and the cornstarch slowly goes into the bloodstream. We don't have huge amounts in the liver, and we have more for energy there, and we have a happy liver. So this has been very useful to explain not only to children but to parents as well, so that they have an understanding of why we're trying to limit the carbohydrate. Another example is our plate model. Here I've shown you the GSD type 3 plate. So this hasn't been validated. It's not a representation of energy distribution. It's a pictorial example to show to patients. But what we're trying to do is, the main take-home message of this resource is that cornstarch is not just an additional thing to your diet. It's incorporated into your diet. So we try and encourage patients to have half the plate of vegetables. For GSD3, we've got a quarter of their plate to be for protein, and the remaining quarter is divided in between your carbohydrate exchanges and your cornstarch, and both these together provide the energy there. So The next resource is teaching families how to read labels. We have patients that English is not their first language, so we teach them how to use the calculator and read labels. We've also got a bank of resources, and here, for example, is a resource from Carbs and Cals, which we teach them the 10 gram exchanges of carbohydrate. But it is difficult. We all know that carbohydrate is very easy to eat and exceed the amount that we've prescribed. So we also try and give children sort of imaginative ways to increase the amount of vegetables they're eating. Thankfully, in this day and age, there's lots of resources for people who are on low carb diets for the general population. So there are lots of things in the supermarket, and on the right here is pre-packed vegetable rice and spaghetti. So these are things like cauliflower rice or courgette spaghetti to try and increase the bulk of the diet without increasing the carbohydrate. And you can see the little picture in the middle is of an education day when we've got 2 children trying to spiralize the courgettes and having a competition to see the longest courgette that they can make. The next couple of points I just want to touch on is we've mentioned this already about doing a 30-minute post-feed blood glucose check in the home profile. I'm not sure if other centres do this, but we find it very useful because we can actually decrease the amount of carbohydrate if the blood sugars are tending to be on the higher side. And then again, just briefly on the emergency regime, we don't use standard glucose polymers for age. So if you're over 2, we wouldn't use automatically a 20% carbohydrate solution. We base it on the usual carbohydrate per kilo per hour. So if they're usually on 0.35, we would generally do a little bit higher than that, which is so 0.45, so 0.1 above there. And this means that it may not be a 20% solution, it could be something like a 17% solution. So we adjust the recipe to do that. And the reason why is that we don't want to give too much glucose and cause spikes in the glucose and then rebound hypoglycemia. So we have various percentages of emergency regimes. The next slide is explaining a little bit more detail about alternative fuels or ingredients. I won't say too much about the first 2, but I know a number of centres would use lactose-free formulas for GSD 1A, and we've also done this, and we've also added MCT into our patients who have a very limited feed interval. But I really want to just talk about GSD 3 and the limiting carbohydrate and supplementing with protein. So the recommendations are that you would supplement protein to 25% of their energy, or in some publications they put per kilo, so about 3 grams of protein per kilo. At Evelina, our emphasis is limiting carbohydrate and then supplementing with protein. The various publications out there, it's very difficult to identify exactly what it is, which will help with GSD3 and cardiomyopathy. We know that some of the published papers would say that there have been calorie reductions, or they've increased the fat, or they've increased the protein. What we know is that if we can limit the carbohydrate, we can then add in extra protein. We don't do both. We don't add in extra carbohydrate and protein. We would limit the carbohydrate and then add in extra protein. Having the 25% energy is a huge amount of protein, which we find extremely difficult to get our patients to eat on a regular basis each day. So we give a prescribed amount of protein from a protein supplement, so roughly about 2 grams per kilo, and then we add in additional food to that. And with a case of severe cardiomyopathy in one patient, we've actually used the modified Atkins diet. This just shows you that the Renapro, which is one of the protein supplements that we use, we would include that with the glyphosate dose, and you can see that's done 3 times a day. Lastly, the feed ingredients, the glycemic index. So when a child is getting older and we're changing them from formula to food, we would, it's a common practice to make a more of a modular feed. So you just use glucose polymer, for example, overnight, because we don't want the additional calories from fat or protein if they're eating that during the day. But we found that we would always try and include the protein in the overnight feed because it gives a smoother profile, so it reduces the glycemic index. And then the last subject, which is our newest sort of dietary practice, and it's a bit controversial, is the use of blended diets. So for people who are not familiar with what a blended diet is, it is a food, so it's a food that is blended up into a cream consistency, and these can be homemade foods, and you would use a certain amount of different foods and do a certain amount of protein, carbohydrate and fat, and blend these up, or there are commercially available blended feeds made by one of the larger feed companies. We have 2 patients on a blended diet. The older patient, the mum blends her own food and to a nutritional prescription, so we know exactly how much carbohydrate and protein and calories. And the other younger child, we're actually using the commercially available feed. And the reason why we've done that is that we've been able to increase their feed intervals with this blended diet. So I guess it's a wait and see and food for thought. So to finish off, we do all this, and your question probably will be, but is it worth it? What are you actually improving on? So hopefully over the next few slides, I can demonstrate why we think it's worthwhile doing what we are doing in GSD Clinic. So height is a marker for metabolic stability. So we want to make sure that children are growing in height and not gaining in weight. And as you can see on the left-hand side is a graph of our children since 2013, and it's the incidence, the percentage of children with overweight or obese. And you can see in 2013 we had nearly 90% of our GSD 1A and B, which is the blue columns, overweight or obese. And over time we've managed to reduce that to about 65%, and the similar with the GSD 3. Now, obviously, between 2019 and 2021, there's obviously been COVID, and we can all probably think ourselves that we've all put a few pounds on. But it's quite interesting to see that despite this, we've not made things worse in our GSD population. It's stable despite lockdown and probably reduced exercise. But what we want to see is to make sure that they're actually gaining in length or height as well. So despite managing to improve their BMI, we want to make sure that their height STSs are going up. And you can see here we've got the median STS again from 2013 to 2021, and it is going up, which means that their height is improving. Another marker, for example, with GSD3 is the CK. We know that if you're not getting sufficient fuel, you may get rhabdomyolysis and CK may go up. So again, this is a chart showing you from 2009 when our CKs, our median CKs were about 1,600, and we're now halving that to about 800. But this is still an area of improvement, and we hope to work on this a little bit more. And then lastly, regarding cardiomyopathy, we have no progression of cardiomyopathy in our paediatric patients. So that's from our point of view why we think we should we do the things we do. We've also asked our patients what they think, and this is a survey that we did for the patients who are doing home glucose and ketone profiling, and we asked if they preferred to do their profiles in hospital or at home, and you can see it was by far preferred to do their profiles at home. We also we have done GSD education days in the past, and again this is a feedback that we had from the days to show that they enjoyed seeing other families and getting new food ideas as well. So that's our service, but can we continue with this? We are able to, because we have a dedicated team. We have guidelines which we have put in place so that things can follow easily, and we've got a bank of resources. You know, we have nearly 70 patients, so you know, I understand from people in the audience may think that that we've obviously spent a long time doing these resources, and other people may just not have the time. But because we've got such a huge amount of patients, we have given the time to do these resources so that it makes it easier. When we have a new diagnosis, we have a pack to give them. We have different resources for pictures, for different food exchanges. We have templates for the dietitians to follow, and which makes it a little bit easier. We also want to thank, we've got a dedicated metabolic inpatient ward, so the staff are familiar with the patient's treatment regimes and the processes there. And that leads us to the end of our talk today, and we just want to say thank you to our team. We have a team of consultants, dietetic colleagues, my dietetic assistant, and our nurses, and of course our patients, and we'd like to thank you today for listening.
Thank you.